Hello everyone, we are now going to go over the flow cytometry plots from the peripheral blood of a 55-year-old man with absolute lymphocytosis and lymphadenopathy. Let's start with CD45 versus side scatter. And here we see different populations in the lymphocyte gate. We have these bright CD45 cells like normal lymphocytes that with low side scatter, but we also see a population that has variable side scatter starting from cells with low side scatter going all the way up across the monocyte gate with high side scatter and bright CD45. And we also have a granulocyte population that is that has high side scatter and dimmer CD45 than monocytes and lymphocytes. And the monocytes are shown here in green, which are not prominent, maybe just few monocytes are present. The next plot with CD19 versus side scatter, we see the 19 positive B cells here. The cells that were in the lymphocyte gate with high side scatter do not express CD19, so they're negative for B cell marker. And in kappa lambda, we see the nice polyclonal background B cells, and our population of interest painted in pink is negative. And in CD5 versus CD19, we see that those pink cells are probably hiding behind this orange population. Actually, in CD5 versus 20 and 5 versus 3, we see that very clearly. Our pink population is positive for CD5, and it has a variable CD3 expression, I mean dim to negative, you can say, and we have the background T cells for comparison here, but it does have CD3 though, and it is positive for CD200 and it is negative for CD10. So it looks like it is a T cell population with variable CD3 expression and CD5 expression. No B cell markers are seen. Now in the next tube, which is a T cell tube, here these abnormal cells or the cells of interest are painted in dark blue, and these cells express bright CD2. We have the background T cells here that are positive for CD7 for comparison. These cells actually have brighter CD2 than the background normal T cells. They're negative for CD7, so like you can say it has lost CD7. They're negative for 16 and 56, and we have our NK cells, which are here, that are positive for 7 and CD16 and 56. And our NK cells are also normally negative for CD3, like the ones that we see here. And these blue cells, like we saw in the previous tube, they have heterogeneous CD3 expression. Some of them are dim, and some of them have CD3 expression similar to the background T cells. They're negative for 1656 again, and they are all CD4 positive. So we don't see anything that is negative for CD4. That is the CD8 positive cells are painted green here, but we don't see anything here. So they are all CD4 positive. So that is similar to, in the B cells when it is kappa or lambda restricted, we can use CD4 and 8 as something similar to that in the T cells. So this is CD4 restricted. They're positive for CD5, no CD7 like that we saw before. And they are negative for CD10. CD10 is important because mature T cell lymphomas that are arising from the T follicular helper cells, like T follicular helper cell lymphoma and angioimmunoblastic T cell lymphomas, those express CD10. So CD10 can help differentiate between mature T cell lymphomas of T follicular helper cell origin and the others. So we have a T cell population that is CD4 restricted with dim CD3, bright CD2, CD5 is positive, and have complete loss of CD7. It also expresses CD200. So one thing about mature T cell lymphomas is that you cannot really call them, give them specific names unless you do additional workup. Like for example, if you do suspect ATLL, you can add CD25. If you suspect pro-lymphocytic leukemia, T pro-lymphocytic leukemia, you can add CD52. So if you add those tubes and also if you have a confident diagnosis in the tissue, then you can put a name to it. But mostly by flow, the only thing that we can say is aberrant T cell population. And we describe the phenotype of the T cells, and we list out what aberrancies we see. So that's what we are going to do for this case. So in this particular case, the patient had a history of PTCL, so we did not require additional workup. But normally when you see a CD4 restricted mature T cell lymphoma and you don't have a diagnosis, you can add tubes with CD25 or CD52 to further see what type of lymphoma it is. PTCL is a peripheral T cell lymphoma. Is a rule of diagnosis. You have to make sure that this lymphoma does not fit the criteria for any other specific T cell lymphomas, like T follicular helper T cell lymphomas or ATLLs or anaplastic large cell or any other lymphomas, and only then it's like a waste basket. And everything else is it doesn't fulfill the criteria for anything else. You can put it in peripheral T cell lymphoma. So these can sometimes or very rarely be positive for CD10 and CD30, and that kind of makes it difficult to distinguish them from ALCL or AITL, but they are usually negative. But in any case, you're going to list out the aberrancies and then say in the top line, aberrant T cell population identified, and give the percentage. Thank you.